Hello and welcome back to episode 51 of the Newbie Dentist podcast. I'm your host, Dr. Omid Izami. In this episode, I sat down with my good friend and New York-based endodontist, Dr. Stephanie Tran, at Her Holiness the Pulp on Instagram. Back in 2018, on episode 22 of the podcast, we recorded our episode called Endo 101. And this episode blew up and quickly became one of the most downloaded episodes of the show and remains in the top 5 to this day. And that is why I'm super excited to have Stephanie back on the podcast today talking some endo. In this interview, we talk about pre-treatment radiographic diagnosis and case assessment to help you guys stay out of trouble in those tricky cases and help identify those sticking points before you start. We also review some clinical tips and tricks and spend some time talking about the endo restorative workflow and why it is important to have that restorative plan in mind prior to referring to your endodontist or starting root canal treatment. This episode is brought to you by my good friends at Henry Schein. With over 60,000 products available from consumables, CAD/CAM technology, lab and large equipment, and of course, all the courses and events that they run, you can always rely on them to be your trusted business partner every step of the way. As always, I just want to thank everyone for continuing to support the podcast. Reaching 50 episodes was a huge milestone, and I am very excited to bring you guys the next 50 episodes. If you have the time, it would mean a lot to me if you can head over to iTunes, give the show a 5-star rating, and leave a review. And if you have friends, colleagues, and classmates who you think may enjoy the podcast, please be sure to share it with them to help us grow the community and provide more value to a lot of the dental students and young dentists out there. Without further delay, I hope you enjoy this interview with endodontist Dr. Stephanie Tran.
Hello, and welcome to the Newbie Dentist Podcast, the safe place for newbie dentists to connect, collaborate, learn, and grow. The Newbie Dentist Podcast aims to provide high-quality and high-value content for all the newbie dentists out there. With your host, Dr. Omid Izami.
Okay, so I'm here with Dr. Stephanie Tran at Her Holiness the Pulp. We're doing episode 2, which is kind of cool. We did one about a year and a bit ago, and I know a lot has changed for both of us in our practicing life and our regular life as well. So it's exciting to catch up again and talk some endo with you. So thanks again for coming on.
Thanks again for having me. I'm really excited to be on again. It's been a while since you and I have talked, and so it's really cool to kind of see the changes for both of us. So I'm excited to talk to you again.
For sure. So we were talking a little bit before the interview, and we're kind of seeing which topics we think will be high yield and people get a lot of value from. So let's start off because we've got a lot to kind of get through today. So one thing I want to kind of start off with was, I think, a practical tip for general dentists, which would be the radiograph side of things. So patient walks in, you take a PA, you've diagnosed it with, pulp necrosis, symptomatic apical peritonitis, whatever it may be, and you're considering starting the case. So what radiographic signs or things that you've kind of picked up over the past couple of years of working now as a specialist, what should we watch out for to avoid trouble and stay out of trouble, essentially? Because I find myself, just from personal experience, sometimes I'll look at, it looks pretty straightforward, so I'll start the case and it's a little bit trickier. Either I can't find all the canals or I can't negotiate the canals. And I'm wondering if there's anything that I can or we can all watch out for on the radiograph that might give us some hints as to which is going to be a tricky case or not.
Sure. There's a lot. So the first and foremost, whenever it's multiple canals, it's always best to take 2 PAs, one straight on and one off angle, either from the mesial or the distal. Okay. The reason is because there's so much information, even just from 2 PAs. Of course, it'd be nice to have a CBCT, but on that note, just as a specifics, the CBCT has to be a small field of view with a very high resolution, or else if you're using like a normal CBCT, the way it is for like implants or perio or surgery, the resolution is too low to really, really see like all the canals or really see really fine details. So taking a giant full arch CT on every endo patient, I would not recommend.
Yeah.
Back to the thing, 2 PAs, and then looking for the nuances in between. So looking for curvatures. Secondly, if you're looking at the canals and the canals have the radial opacities inside of the pulp chamber, then you can expect pulp stones or like some sort of dystrophic calcification. Also, to keep in mind, like an average measurement of how far the pulp chamber is from the occlusal table The rule of thumb is like the rule of 7. So 7 millimeters is about where you should start looking for canals. If you're getting past 8 or 9 millimeters in an access, that's like very dangerous. And then that's a concern, and maybe stop and reassess. But having that distance, even on the radiograph ahead of time, is very helpful to help you gauge where to access and how deep to access. And then that way you can be aware of like possible perforations. Another thing is looking at the canal itself, how thin it is, how easy it is to see. So that will tell you how calcified it is.
Yeah.
And if you can see the canal and all of a sudden mid-root it stops, like it all of a sudden disappears, then most likely the canal has split. Otherwise, I mean, sometimes it's like calcified, but it's usually either a split or like a crazy curve somewhere. That's why it would suddenly disappear. Another thing is looking for the periapical radiolucency. So the shape of the periapical radiolucency will tell you a lot. So if it's slightly off-centered of the root, that tells you that there is likely either a second canal or a split, like a split in the canal system, or a curved canal. It could be one canal, but it's curved. All those things are possibilities. So those are some things to keep in mind before you start to get in. And if it is like super curved or has an extra curvature, then that's the kind of case where you definitely want to pre-curve the hand file, a small hand file, like a 10C or 15, to try to get into that curved apex. The other thing is looking for nuances in the canals themselves. So like a molar, a second molar, if you take a couple angles to see if the canals merge or if the roots fuse. So then that helps you kind of suspect ahead of time if there might be a C-shaped canal system or merging of the canal systems. And then that way you can be prepared, like if the canals do join, how to prepare the two canals like that.
So for the rule of 7, where do you measure that from? Is it just from like the cusp tip?
From the occlusal table. So, the cusp tip, it would be the cusp tip to the pulp horn, or the occlusal table to like the pulp chamber
floor.
Yeah.
Okay, that's pretty cool. So take 2 views you can see a little bit more perspective on it. What about like mid-procedure? What can you gain like from taking some radiographs during the procedure with like a hand file in there or a GP cone in there to kind of help guide you if you're kind of a little bit lost?
Sure. If you're kind of not sure if you're even in the canal system or if you're in the pulp chamber at all, then you can take a radiograph and put a file into what you think is a canal, just to make sure it's actually a canal and not a perf or something like that. Other thing is midway, let's say you're instrumenting, but you're starting to hit a hard stop. And in that case, you want to go back with hand files, see if you can pick around, see if you can get like a stickiness where it tells you it might be a canal system. Place EDTA in there, put the hand file in, and then take a radiograph and see if you're starting to be excessively straight and going in the wrong direction, or if maybe you're hitting a curve and you're hitting a ledge. Those will all tell you that type of thing.
Okay, so that I know it's a little bit off topic, but that hard stop feeling, what is that normally? What's like the main causes? Because I feel like when I feel that, I know something's not going right, and it's always not like I'm not sure if I ledged it, or is it just like am I hitting like between a perforation between like 2 like split canals, or how do you normally manage it once you hit that, like get that hard stop feeling?
So the rule, I mean, a good thing to keep in mind when you're instrumenting, it should feel like it's when you are doing like the pecking motion or the slight, like you're guiding the file forward, whatever, it should always allow you to progress forward. And even if you back up, just back up a little bit and it should continue to progress forward. So it's like, I kind of say it's when you do this bump, bump, bump kind of feeling, it's 2 steps forward, 1 step back, 2 steps forward. So each bump will be, you're not pulling your file out all the way, you're just backing it out a little bit so it's no longer bound, and then guiding it forward a little bit more. When it's getting a hard stop, that means you're taking a file down and it's not going anywhere. It's truly hard. Then I always go back with a hand file, usually a 10. Then I will pre-curve it and see if I can get to my sticky point again where the canal system is. So you don't ever want to force the rotary file down. So you take a hand file and it should feel sticky and you pre-curve it. I pre-curve, it's in my highlights in my Instagram. So you can pre-curve just the apex, like a 3 millimeters, either with your nail or with a cotton plier, and you guide it and you twiddle in. So I talk about twiddle and filing. So you're just almost like a watch winding, like back and forth down, gently guiding it down. If you get a stick, when you progress your hand file forward, it should want to go forward a little bit, and then you can draw it out and like file. So all that is a hand filing technique to help you get back into a canal system. That pre-curving means that maybe it's curved.
Yeah.
So then maybe you're going to get back into it. Those hard stops can mean a variety of things. Number one, that you're ledged. Number two, that you've broken the file in there, separate a file in there, and you're just hitting the file.
Yeah.
You want to back look at your file. It can also mean, sometimes it can mean an apical delta, but apical deltas are not usually that far up mid root.
Yeah.
And you are often able to get into one of the canals of the apical delta. It's more commonly that you're starting to go in the wrong direction, so you can be transporting the canal system, you're ledging the canal system, or you've blocked the canal system either with a separate instrument or with too much debris. So sometimes you can actually block yourself out, and then the tip will start going in a different direction because it's blocked out with so much debris, which is why recapitulation and getting patency again with a hand file is so important.
Yeah, for sure. Yeah, so if you've ledged it, so once you've kind of like watch wind your way, if you get past it and you do your filing, is that pretty comfortable then when you go back to the rotary that will actually bypass it, or it's not always that easy?
It can be, but it means that you have to make sure you get in there first with the 10, then with a 15, and the 15 should be able to go in patency, and you have to pre-curve it. You can also try with a 20 as well, just to make sure you have a really clean, smooth path. And then a lot of times you probably want to use a slightly smaller file that is controlled memory, so you can pre-curve it into your original canal system.
Okay, so it's not a straight.
Yeah, it's not. It can be, but it depends on how ledged it is and how involved it is, and if you have a controlled memory file to get back into it. Another technique is like the balance force using like specifically Roan files, but that's a very advanced thing. It's very hard to do with like large hand files. Wouldn't recommend that one. Pre-curved controlled memory rotary files after getting a really, really good glide path with hand files is going to be the most straightforward.
Okay, so get it at least up to a 15, ideally like a 20 to bypass. And
so like if you can get your 20 in there to patency, then you should have a wide enough path, and then start with a smaller pre-curved controlled memory file.
Okay, so you've taken a PA, you start the case. When's a good time to like call it quits, like, and stay safe?
Yeah.
Like when should you know, like, okay, this is maybe not going right, or there's something abnormal going on that I should probably not like keep going?
Sure. If your access is getting excessively wide or excessively deep, so starting from the top of the procedure, right? So starting from their access, if your access is excessively wide, excessively deep, and you still haven't found all the canals, like you're expecting how many canals, that's one place to stop. Another is if your files are not advancing as easily as you thought they would be. So like if it's a really, really calcified case, that might be a time to call it quits. Another thing is if you're trying to go and your rotaries are just not advancing much at all, and they're starting to go maybe in a questionable direction, then that's another good point to stop. So all the earlier points are a lot easier, because once it's really, really late in the procedure, it's a lot harder to fix.
Yeah.
Yes. Oh, sorry. One thing I just remembered. So with the looking at the radiograph for the distal canal of a lower molar, one of the things to look for is when you're taking the multiple angles, you want to look for quote unquote 2 PDLs of the walls of the distal root. And the reason is because if it looks like there's 2 that are next to each other, then there's a good chance it's either a figure 8 shaped canal or 2 canals. And then you want to try to be looking for a second canal. So if it's figure 8, then you're not really trying to look for another canal. But if it's like you're only finding this one perfect little canal and it's not centered with the 2 mesial canals, you want to try to be looking for that 4th distal canal. So that's one way to look for it. You look for 2 PDLs on the walls of the distal. Yeah,
radiographically. And so when, I'm just curious, like when you say this, like you're doing a lower 6 and you open it up, when do you know it's going to be a pretty slam dunk case versus like is it when you like your 8 file just goes into length the first try, or like how do you know like, okay, it's gonna be pretty straightforward and you can like kind of relax?
Oh yeah, so you can easily see all your canals, like boom, right away you see all 3 or 4. And yes, if I put my 10 in, actually a 10, if a 10 is loose, like I can go into the apex and you can do just a quick check, you check with the apex locator, rings red right away at about the estimated working length you thought you were going to be. Like you measure the radiograph ahead of time, you think it's about 20, you're getting red at 20, you're checking your EAL, your apex locator. then yeah, if it's a loose 10, you're good.
Okay.
So if
Sure.
you have a loose 10, you know you can get a 15. And if you have a 15 to patency, that's a 20. You have the 20 to patency.
Mhm.
And so then you know you can get rotary files in there easily. So loose 10, easy 15, and easy 20.
So do you normally go up to 20 before you start rotary, or?
I only check with a 10
Yeah.
and then make sure I can get my 15 to length. A lot of manufacturers will tell you, oh, make sure you can get a size 20 hand file, or a lot of people learn in school, make sure you have a 20 hand file before you start to use your rotaries. But the problem with the size 20 hand file is the size 20 is the point where the files start to get a little too stiff. The hand files start being a little too stiff. So if you're trying to actually instrument with the 20, there's such a high chance you can transport the canal. So it's not about using a 20, it's knowing you have a 20. You know you have a 20 when you have a 15 that's a little long.
Yeah.
Because a 15 is long, then a millimeter up from 15 to 17, you know, that kind of thing.
Yeah.
So if you have a long 15, you don't even have to put the 20 in. You already know you're at a size 20.
You're doing a good shape. One more quick one. This is fun because I just asked my little troubleshooting.
No, that's what I'm here for.
So for example, like some premolars I find, or the distal of some lower molars, I'm not sure if it's like either a wide orifice or if it's like two close canals. What's like an easy way of just like checking that to make sure, like, so you know?
Oh, I'm sorry, are you asking like if it's one or two canals, or if you're trying to look for a second canal?
No, like you found it and it looks like you said, like the figure 8, or if it's just like a wider orifice. Sometimes I'm not sure, I'm not sure if I'm like going in and it's kind of like a large like taper naturally. So or it's like two separate ones actually. Like it's tough to kind of differentiate sometimes.
Sure. Number one, treat them separately as two canals nonetheless. And two, if you want to check it for yourself, you can put two hand files in and see if they meet, or see if they start going different directions.
Yeah. Okay. So that's pretty easy one.
So take a quick radiograph with two hand files in it on each side. And if you put one hand file to like length and the other file stops, like it is shorter than your working length that you found, you know that they join.
Yeah.
If you want to know if it goes to your working length, then you know that they're separate. If you're not 100% sure if it's two separate canals that are joining or one big one, it doesn't really matter because you need to treat them separately anyway. So you would instrument both sides of that figure 8 as two canals that join, and then fill it like two canals that join.
Yeah.
And then you'll see the radiograph if there's any tooth structure in between.
Let's talk quickly about, the state of endodontics. I know you're a young specialist, so it's nice to get your kind of input on it. You're kind of new into the field and been working for the past little bit now. So someone listening who's maybe like just finishing up a GPR or has been working for a couple of years and they're kind of considering getting into endo as a specialty, what's your take on it and how things are going to be going over the next like 5 to 10 years? Would you still recommend it to someone having been in it for a little while?
For sure, if they really, really, really love it. No matter what they do, no matter what thing that they are thinking about with their lives, like if they are a residency, if they're currently practicing as a GP, if they want it enough, it's worth going into it. But you have to actually love it, because like people always worry, oh, is endo gonna die? Oh, is is ortho going to die because of Smile Direct Club and all that stuff? Oh no, the specialties are always going to be around, but you're always going to be able to do well for yourself if you clearly have a passion for it, because no specialty, no field, no matter what kind of money you're making, is worth it unless you love it. There's always going to be tough days in every specialty. There's always going to be situations. There's always going to be tough situations with politics and capitalism and with how companies come and go and all that stuff. There are always going to be difficult things, and people are going to get scared, and they're going to go Chicken Little and like, oh my God, the sky's falling.
Yeah.
You know what? It's always going to stuff that, and it's always going to ebb and flow. It's about, if you love it, people are going to come to you. You're going to you're going to make it better for patients no matter what. The nice thing, I think, is that as young dentists and as the way healthcare is developing, I think there's a lot of opportunities and a lot of changes to the way healthcare is being done. It's not just your same old, oh, you graduate down school, you hang a shingle with your name on it and you open it and that's it. Like, if you want to, yes, you can, but that's not your only option. So the nice thing about with any kind of part of dentistry, but including endos, there's different ways. You can do solo practitioner, and you can do group practitioner, you can do multi-specialty, you can work for DSOs and big corporate kind of groups.
Yeah.
There's a lot of work. And then obviously with like academia or public health or whatever. The nice thing about the other two, so either multi-specialty or big corporate or whatever, is that it's a little different, yes, but it's a good fit for some people. And the biggest thing, and I always tell this to dental students who ask me, or people, young dentists who ask me about my take on these things, it's about knowing yourself and knowing what you want from a practice. What are your values? What's important to you?
Yeah.
What are your like hard stop negotiation points for anything? You know, it's just like dating. Everybody's individual. You have your like non-negotiables. You have to have your non-negotiables as a dentist. And honestly, people are not always going to know what those are until they practice for a while.
That's right.
You know, so some people are going to love solo gig. Some people are going to hate just being by themselves and want to be in a group. Some people don't want to be like the junior associate and have to go up the ranks in a group practice. Some people don't want to run the practice ever, and they just want to be an associate in a group or in a corporate or whatever it is.
Yeah.
Some people just want to bang out cases in corporate and, you know, whatever. Some people love working together with a whole bunch of different specialists in a multi-specialty because you're working together as a team. Some people want to have other people of the same specialty to bounce off ideas off of, and some people just want to be the head honcho. They're the only one. They don't want to talk to anybody else. You know, some people only want to do academia. It's hard to
a lot
say,
of options for sure.
Yeah, tons of options, and it's about like knowing yourself and what you want from a practice, whether it's like a ton of patients, very few patients. You want to have a super flexible work schedule, or do you want to have just the same place every day, like, because you know you like that consistency? You want to have like a whole team together, or you like to be just by yourself making all the decisions, you know? So that's a tough kind of thing for a lot of people, but it's just about kind of figuring yourself out.
Are you looking for ways to save money in your practice, but not really sure where to start? Look no further. Henry Schein 360 has taken care of all of this for you. Your benefits begin at 4.5% cash rebate each month on everything you buy at Henry Schein. And you can access an average of 15% discounts off products you use every day. Now, here's the exciting part. Henry Schein 360 has also teamed up with businesses that you deal with on a daily basis to help save you thousands every year. Our program partners cover areas such as practice analytics, website design, credit card merchant fees, online marketing, and inventory management. Contact your local Henry Schein territory manager to find out more. Yeah, and what do you, amongst your colleagues and stuff, what are you seeing as a main trend? Are a lot of people gravitating towards like a visiting in-house specialist in a group kind of setting, or are people still doing the traditional like endodontic center, come see me and I'll do your endo for you on a referral basis?
I think that there's always that group model, or group practices of the same specialty are always going to be really big because there's safety in numbers. Number one, you get to share all the responsibilities and the costs and the overhead and stuff like that. So I think that's always going to be a big one. But I've seen definitely a rise in multi-specialty, both on the DSO, like corporate level, as well as the private sector. Yeah. And the reason is, I think there's a lot of reasons. Again, safety in numbers. Corporate, there's a lot of people who either don't want to ever run it themselves, or they like to have that safety net of a corporation, like they know they're going to have a ton of patients. Yeah. And then also I think this is a factor partly with our generation, is that we like to work together. Mm-hmm. I think our generation really like does a lot of collaboration and kind of cognitive collaboration. So on top of that, you see a lot of how dentistry is all interconnected, and that it's not just, oh, here's a prescription for an endodontist, like get a root canal. No, I mean, there's so many nuances of like treatment planning and restorative concerns and endodontic prognosis and perioprognosis and all that stuff, that it's really easy when things are all together. So I think that there's always going to be those two things, but I definitely see the rise of multi-specialty or like larger groups. That's pretty cool. And I think it's a nice setting to work in. Like you said, when you have other specialists or other even general dentists that you work with to bounce ideas off each other and plan cases together, you can get a lot better result for the patient, which is pretty cool. And I like that. I like that our generation is a little bit more like collegial and interacting with each other. I find it's funny because when I go on Facebook, you know, the demographics is a little bit older than like Instagram and stuff. Yeah. So on Facebook, there's so much like, someone will post a case and instead of like support, there's always like that one old guy who's like, oh, I could have done this better, or like this and that. So it's great that I think our generation, our millennials kind of coming up, especially through Instagram and other like media platforms, are able to like collaborate and share cases and help each other out. And I think it's just really helping accelerate people's like learning curves. Like people are just getting so much better quicker with having that much support. So you mentioned the multi
kind of discipline. And I know I've been like past few episodes, I had like Davey Alman on, and we talked a lot about biomimetic dentistry and the restorative side of things, which is something that I really enjoy doing. And I know the biomimetic guys and the endo guys maybe have different goals because their whole aim is to like avoid endo, right? So try and save the pulp if need be. Unfortunately, sometimes it doesn't work out and the pulp does flare up, and sometimes people do need endo. So with the endo restorative aspect of things, I know that's an area that you're really passionate about and lecture on and things. So let's maybe from an endodontic perspective, how do you facilitate the restorative side of things? So if you maybe talk to me about like that interaction that you have and maybe a couple of examples, that'd be really cool.
Yeah, sure. So I try to work really, really closely with my restorative doctors, and I try to tailor things a little bit to what their preferences are and what they're like, if somebody's like hardcore biomimetics versus somebody who has a different treatment plan for a patient, because there's different patients who are going to be like, certain patients are going to be a fit for like pure biomimetics. Some patients are not going to be a fit for that. And you might just have to do amalgam or whatever, like. There's just some patients that are different, right? So it depends on the patient. I hate making these like blanket term statements that some people like extremists might use for either way, like never endo or never whatever it is, because there's so many possibilities and different factors. We know that as dentists, we know that our patients and their patient factors, there's so many little things that will affect our treatment planning. So by working together closely with the restorative doctors, I'm able to tailor a treatment plan a little bit better. So it's things like whether or not it's restorable versus not, right? There are some cases and there's some patients, no matter what, even if it looks really questionably restorable, but you just have to restore it because of X, Y, and Z. It's the patient's only posterior tooth. They are not a candidate for implants for whatever reason. They seriously do not want to extract their tooth, or whatever it is, Then there's just some patients where even if it's probably close to restorable, but is this really a candidate for it? Or is patient expectations and patient management are all factors that comes into play as well. So by working together closely, there have been cases where I'm like, I don't know about the restorability, but the restorative doctor explains to me, this is what my treatment plan is and why. Then you know what? I'm like, okay, I'm on board. I can see why, right? Versus otherwise, if I didn't care and I just didn't ask or whatever it is, I could easily tell the patient the wrong thing. Oh my God, no, it's not restorable. Get it extracted, and the restorative doctor can be like, no, like we can't because of X, Y, and Z.
So
I recently had a case of 2 canines on this adorable little small elderly person. It was really iffy on restorability, but then, and both restorative doctor and she and I both agreed, the restorability is really iffy. It was going to be true heroics. But this patient also doesn't really have much otherwise, right? She only has like a couple teeth here and there, and she was just not going to be a candidate for a full mouth arch implant case. The bone, the cost, all those things, she was just not going to be a candidate for this, So that's why even though the restorative was like a little bit iffy because of those other patient factors, I did the endo, she did the restorative. They did like, I think, cast post cores and stuff like that. And it's on the heroics end of things. But it's an elderly woman, that kind of thing, that we're just going to try to maintain this case. Another one I had recently where I didn't even do the endo, really nice elderly man, large, like slightly large caries on one tooth, and another tooth had crown, recurrent caries, close again to the pulp, quote unquote. And that's why he was referred. But he's also like 90 years old. The pulp is calcified there's like no pulp at all in that chamber. And if we really start nitpicking every single margin, you're looking at replacing every single crown in his mouth. He's had these crowns for like 20 years. The rest, the restoration had like a deep caries, but there's no pulp really in the chamber anymore, so it's not that close to the pulp. And he can't really feel cold on a lot of teeth, and there's no lesions, and he's completely asymptomatic. No, I talked to the restorative doctor, and she and I were both like, well, let's not. We're not going to do endo on this case. He's happy because he's not getting endo, but also these teeth they're all questionable. Like all the margins are questionable. We're not going to subject this poor 90-year-old man to replace him with a crown in his mouth, So there's different patient factors. I'm sure a lot of your viewers are going to disagree with me on a case or whatever, but it depends on patient factors. It depends on restorative factors, all those things. Back to the biomimetics and that type of thing, because the whole point of biomimetic dentistry, not about pulp or not, but more importantly, it's about restoring the tooth and how, right? You need to have the proper bonding protocols to give the tooth the best possible option. So on part of that is conserving as much tooth structure as possible and adequate access, right? So for conserving as much tooth structure as possible, the nice thing about endodontics is that so much has advanced that has allowed us to maintain as much tooth structure as possible. We're able to do smaller accesses because there's better understanding of the anatomy, there are better radiographs, there's CBCTs, and there's better illumination and magnification. So we can do smaller accesses to do the same thing. We can still clean out the caries, we can still clean out the pulp and get out the tissue with still getting smaller accesses. We're able to do smaller instrumentation and still be able to irrigate and instrument well. We now have like better, we have more technology for the instruments, so controlled memory, different types of heat treatments, different types of instruments with smaller maximum flute diameter, so just really, really thin instruments and really flexible ones. So we're able to maintain the curves and maintain the tooth structure. And then additionally, we can have better irrigation and cleaning. You know, there's activated irrigation, there's good research on different types of irrigation and different irrigation protocols that we can get the tooth really clean with smaller shapes and still do everything. So we're able to conserve tooth structure on the endo side of things. Then on the access side of things, we can still maintain a smaller access, but still have it adequate access for the restorative doctor to do all their proper bonding protocols. Because I think that's really important. It does me no good to do a tiny, tiny, tiny root canal through an access that no restorative doctor can get etched and bond properly in or out. You know, like, okay, then now I've made more of a headache for you and me. I mean, that's not good, right? Yeah. So being able to have a proper access where the restorative doctor can get back in, know what's there, and be able to get to do all their proper bonding protocols is really important. So I'll do I could still do a really small access, but do it in a way where the restorative doctor could still see everything themselves, you know, with loops and a light. They don't need a microscope. Even if they don't have a microscope, they can still see everything. They can get their microbrush down to all of it. There's a lot of tooth structure left there. So if they need to adjust anything, or they can choose to do whatever they want with the tooth, right? If they feel the tooth is a candidate for like a biomimetic crown, or like they want to do a CEREC, or if they want to do PFM, whatever they feel is appropriate for that patient, they can, because now they have all the tooth structure that they need to do it. So I think those are working together closely and knowing the restorative capabilities of that tooth for that doctor, and then being able to do the proper bonding protocols are all really important.
I'm curious, what is the percentage of, you know, the cases that get referred to you that they ask you to build up a core? Or is it normally that they just say temporize it and send it back to me?
It depends on the case. So one of my offices, which is a multi-specialty practice, we've grown the practice enough that actually there's a lot of patients that need, you know, some sort of direct cuspal coverage crown lay, in whatever you want to call it, restoration on top of it, but the patient might be waiting for a while because of scheduling or whatever it is, right? So I actually do the core buildup. I already talk about it with the restorative doctor ahead of time. They're cool with it, so they don't want the patient to wait. The most important thing is we all want what's best for the patient. They don't want the patient to wait a long time. I don't want things to be temporized for a long time, so I'll do the restoration too. And I try to learn from everybody, like on Instagram, from biomimetics dentists, from trying to perform it at the higher levels of bonding protocols, so that I can properly have a good restoration for the patient. We'll talk about cases ahead of time too. If I see that there's, you know, it's going to be a really difficult case for me to restore, you know, because my restorative capabilities are going to be different than somebody who does it all day, every day. Or if I don't know for sure what kind of crown or whatever they're planning, you know, do they want to keep the crown that's there? There's different patient factors there for that as well, you know. So some cases I won't, but if there's any questions, we talk to each other a lot. So there's partial fractures, no post, please. Yeah. You know, that kind of thing.
Yeah. And what's your thoughts on like the whole like deep margin elevation? Because I know like from an endodontist perspective, you think it's an effective principle that can give good long-term results, or is there like much literature on it from the endo side of things that can cause leakage and cause issues down the line?
I think that no matter what, it's about doing a good restoration, whether it's deep margin elevation or crowns, or, you know, even if it's just a class 1 access prep restoration.
Yeah.
No matter what it is, there has to be good restorations, good ponding protocols. If it's done well, then it doesn't matter what is in there on there, or if it's a margin, one margin or another, So no, there's not a lot of great endodontic literature, and some of the endodontic literature on it is about amalgam or very outdated ways of restoring teeth. So that's the thing. A lot of restorative doctors will ask me similar questions about not just deep margin elevation, but restoring an access through a crown versus doing a new crown. I've got about like composite versus amalgam. Here's the thing. My problem with the endodontic literature is that the endodontic literature is going to be based on what they learned, which is outdated restorative techniques, which is not their fault. They're just, when they do inherently the literature is flawed because they're doing the literature and they're doing the protocols based on what they know, not based on what is the most current, because it's impossible for every endodontist to keep up to date on every restorative technique. Like I try to keep fairly up to date, but that's even hard for me, I try to keep somewhat up to date, not so that I can do every restorative case myself, but so that I can communicate better with my restorative doctors. But if the people who are doing the research are going to be doing slightly older techniques of bonding, of stuff like that, so by definition, their findings are going to be flawed, a little bit flawed, or some of the literature itself is outdated using older techniques, so those are not really valid. You can't compare them, or an access of that style back then that was much larger you can't really compare versus an access now, or the restorative now. It's going to be a PFM versus a crown lay or on lay. How do you compare that?
It's hard to stay on top of things, because I think even would have graduated from dental school like 2-3 years ago, you feel like it's already changing. You gotta like stay on top of the literature and like keep going to courses. I think there's like a couple of pros and cons. I think Instagram is good for kind of keeping up with what people are doing around the world, like latest trends. The one downside that I think, and one of my friends actually brought this up, I hadn't really thought about it, is because you see people doing stuff on Instagram, different types of cases and things, it might be that it might not always be like evidence-based stuff that they're doing. So if you kind of just blindly copy what other people are doing or try and mimic what they're doing, it may not necessarily be like the right thing to do. So I think it's something you gotta be really cognizant of as well, and make sure you're not just like blindly just doing things because other people are doing it, and make sure it's actually backed by something. Exactly. I think it's a bit of a challenge for sure.
Yeah, and that's unfortunately the problem with a lot of medical instruments or medical like devices and medical materials, is that they release something, but the research on it is not super it's not long term yet. So with all the restorative stuff, I think looking at the restorative literature is going to be more up to date than pure endodontic literature. So that's why for restorative stuff, that's one thing, whereas for the endodontic, like pure endodontic treatment, then looking at endodontic literature is different. So it's like, it's just as an example, it's like pulp caps, the restorative literature pulp caps are not the greatest because they're not using the most current materials often. They're looking at older techniques and older materials and things like that, which I get. That's what they were taught. Yeah. And then whereas the endodontic literature for pulp capping is going to be different. So even like biomimetics of Vitribond versus other restoration materials, it's all that kind of thing, I think it's just a different comparison.
Yeah, it's interesting. I hadn't thought, because if you look at similar subjects from different perspectives of different specialties, each discipline is going to have their own perspective on it. So they don't always necessarily match up. So it'd be nice to like see like a joint paper of like endo restorative with like endodontists and a restorative dentist like collaborating on it. I think that'd be a pretty cool, pretty useful one to have. Because I think, like you said too, with like the like ninja accesses and stuff, it's cool because it saves tooth, but if the restorative dentist can actually like fit a micro brush down, or the depth of cure is not going to be good enough for the composite in there, it's going to always like have those issues with it as well, right? And I know even
don't say that to the extremist endodontists. They're going to hear this podcast and be like super angry with me. Like it's different. It's just how you manage the accesses. That's how you.
But I know a lot of endodontists are not even like super keen with the ninja access, so.
Yes, that is an inflammatory subject, but we will not talk about it in this podcast.
Yeah, we'll let people use their imagination on that one, I guess.
Seriously, go ask the endodontist. It depends on the situation. Yeah.
But it looks so good radiographically. I think that's why.
Exactly. It looks cool. It looks cool from a restorative standpoint.
Yeah, yeah. Awesome. So I think when we did the podcast last time, I wasn't doing the rapid fire yet. So we'll do that with you today
Oh,
to wrap things up.
okay.
So,
What?
so what's your favorite pizza topping?
Pepperoni.
If you weren't doing dentistry, what profession would you be in?
Pastry chef.
Nice. What's your favorite tooth to work on?
Lower 6.
And what's your favorite like musician or artist or band?
BTS.
K-pop.
K-pop. Or Young the Giant for American music. So, yeah, those are my two. BTS or Young the Giant.
What do you listen to at work?
Usually older rock. So Beatles, Aerosmith, like that type of stuff. Just because that's a general crowd pleaser.
And what's your favorite Instagram account to follow?
Kirti.
Yeah.
Yeah. Kirti, and so she's one of my.
She does really good work. Yeah, she's super nice as well. Super positive in the community as well, which is pretty sweet.
She has, because it's not just about dentistry. Like obviously, yes, her dentistry's amazing. Her CEREC crowns are just incredible. But she has like really good kind of thought-provoking stuff, you know? So I really like hers a lot.
Yeah, she's super nice. Awesome. Thanks for coming on. We'll get this part 2 out, and hopefully down the line we'll do a part 3 as well and see if there's any new changes going on in dentistry that we can kind of chat about. I think it's really cool to talk about the endo-restorative side of things, because you don't always think about that from like the endodontist perspective and also from like our perspective. Mm-hmm. So it's kind of refreshing to hear that. So that was great. And for me, it's always fun to do these things because I get to just ask different specialists like my little things that I get stuck in. So selfishly, it's pretty useful for me as well. So thanks for kind of answering those quick questions as well. I think a lot of people will get some value.
Oh, definitely. I appreciate you having me on, and I always love chatting with you, and I love chatting about endo. So this is always good.
Awesome. We'll chat again soon.
Yes.
Take care.
You too.